Here's an example of a common application of AI. A large information technology company sells analytic services to health systems to integrate patients' health data with insurance claims to help reduce inpatient admissions, emergency department admissions, and readmissions, which is when a patient who has been discharged from the hospital is admitted again within a certain time interval, such as 30 days. This example is just one of dozens, if not hundreds, of models that have been developed to predict hospital readmissions within 30 days of discharge. These predictive analytics have been developed in response to the Medicare Hospital Readmissions Reduction Program, or HRRP, which fines hospitals when they have excess readmissions within 30 days, after adjustment for medical risks. This program applies to patients who are admitted to the hospital for a few specific conditions, such as heart attacks or pneumonia. The program was designed to create financial incentives to reduce avoidable readmissions, which were thought to account for up to a third of all readmissions. There's evidence that the imposition of fines does, in fact, reduce readmissions. However, there's also evidence that the way that admissions are reduced might also lead to the unintended consequence of poor or inappropriate care, or no care at all. For example, some evidence suggested that hospitals reduce readmissions by retaining patients in observational units. Others have suggested that hospitals react to incentives by putting pressure on nursing homes not to send patients back within 30 days of discharge, which could delay necessary care. Hospitals can apply this pressure by not referring patients to nursing homes that lead to readmissions. Or patients could be discouraged from seeking timely care or even be less likely to be admitted in the first place if they're predicted to become a patient that is likely to be readmitted within 30 days. So, how information from a predictive model gets used in actual practice is also ethically relevant. Here's another example. A health system develops a model to predict costs of patients who have joint replacements. This application of AI would be developed in response to a type of incentive program to encourage value-based care and is known as bundled payments. These programs focus on lowering costs of care by paying multiple providers for what are called episodes of care for certain conditions. This is in contrast to a traditional fee-for-service payment program that pays individual providers for discrete services. So instead of paying a surgeon, an anesthesiologist, an orthopedist, and a physical therapist separately for a patient's joint replacement, payment would be bundled for all of this care and for the providers as a group, and they would manage the costs. If the costs of caring for the patient exceed the bundled payment, the providers share the burden. If the costs are lower than the payment, providers share what is left. This type of program is not as financially risky for providers as a fully capitated payment model, but it has more potential to control costs than the fully fee-for-service model. The intent of bundling payments for services included in an episode of care is to create incentives to improve patient outcomes in transition from, say, the hospital to a rehab facility or a nursing home through better coordination of care. That is, the intention is to align incentives of providers across a series of healthcare settings. However, hospitals and providers still have an incentive to lower costs and therefore identify patients who are going to incur either low or high costs. And as for the examples we just saw, there are existing health disparities that could interact with the bundled payment programs to exacerbate these health disparities. For example, there's evidence that even though African Americans are disproportionately affected by arthritis, they are less likely to receive joint replacements than white patients. There's also evidence that African Americans are more likely to be discharged after joint replacements to facilities that lead to 30-day hospital readmissions. And again, if predictive models do not include the right data and do not risk adjust appropriately, health disparities could be reinforced. These are the main takeaway points. First, healthcare systems deliberately use incentives to encourage appropriate and efficient use of healthcare resources through improving quality and lowering costs of care. These incentives make it useful to predict risk, especially unexpected financial and medical risk. And AI can be useful for improving the accuracy of these kinds of predictive analytics. Incentives can have unintended consequences, which can lead to poorer care or discrimination against vulnerable groups, or exacerbation of existing health disparities. It is important to understand and anticipate the impacts of proxy measures and the limits of health data on bias in models. It's also important to understand how behavior of those who use the output of models could be affected in ways that could create unintended consequences. In short, fairly sophisticated and detailed knowledge of how healthcare services are delivered and paid for are necessary to understand how to build good and ethical AI models.